All right, good afternoon. It's February 8th, and we are about to have a budget hearing with the Senate Budget and Tax Committee's Health and Human Services Subcommittee and the House Appropriations Committee, Health and Social Services Subcommittee. I'm Melanie Griffith, and we are going to hear first the budget of the Maryland Department of Health, Office of Healthcare Quality. The analyst will be Andrew Garrison. Followed by the Maryland Department of Health, Public Health Administration. Analyst will be Ann Wagner. And then the Department of Human Services, Office of Home Energy, and we'll have Tanya Zimmerman. So members, if there aren't any questions, we'll start with our first budget and turn it over to Mr. Garrison. Good afternoon.
Madam Chair, just before they start, I have some members in the waiting room if staff can work on that. Thank you.
Thank you.
Thank you, Madam Chair. As mentioned, this is going to be the budget for the Office of Healthcare Quality. Can everyone see my screen? So this is a $25 million budget that we're looking at here. And this is the agency department that deals largely with regulation of nursing homes and assisted living programs, as well as other healthcare units in the state. And we're showing a modest increase in fiscal 22 here. What's driving that increase is about 1.5 or 1.4 million in personnel expenses shown up at the top here. And then that's offset a little bit by a decrease in contractual expenditures. What this agency is doing is actually they're ending contracts with the Montgomery County Health Department, who was doing inspections for them on a contractual basis, because they're now able to bring more of that in-house. And that is because of those increased personnel expenditures. In particular, OHCQ is adding new positions as part of a 5-year staffing plan to increase agency's capacity to do more surveys. Is 10 new positions over 5 years, starting in fiscal 20, ending in fiscal 24. So we're near 3 of that. And here in Exhibit 3, what we're doing is we're showing which units of OHCQ and what they've been focused on have been getting those increase in staffing positions. And the reason for this is because traditionally in this budget, we do talk about challenges that OHCQ has had in meeting mandatory surveys for developmental disability facilities, assisted living facilities, and nursing homes, and surveying 100% of those agencies year over year. The one issue I want to highlight in this budget is because of the role that OHCQ plays in the regulation of those nursing homes and assisted living facilities. Collectively, we're calling those congregate living facilities, or CLFs here. Is the impact that COVID-19 has had on these facilities. What we're showing here in Exhibit 4, that outer ring is total number of COVID-19 cases in the state as of about 2 weeks ago when we were working on this, January 20th. And the share of cases that are in those facilities, both for residents and staff, are under 10%. But then in that inner circle, what we're showing is the number of fatalities from COVID-19 that have occurred in these facilities. And as you can see, although the residents of congregate living facilities make up a very small share of the cases that we've had statewide, the fatalities in these facilities have been near 50% of the total deaths from COVID-19 in the state. And this is about 10 percentage points higher than the national average. Nationally, we look at closer to about 40% of COVID-19 fatalities have occurred in these types of facilities. And what we've done here in Exhibit 5 is we've sort of recreated the trajectory of this throughout the course of the pandemic. Again, up to January 20th, when we were finalizing this. But as you can see, there was a spike earlier on in the early stages of the pandemic, and then really leveling off in terms of total fatalities in these facilities, and then picking back up again here towards November and the end of last calendar year. And because of the concerns of movement in and out of the facilities, and particularly how vulnerable a lot of the residents of these types of facilities are, that really limited the ability of OHCQ to do certain inspections and surveys that they normally do. An instance for nursing homes, CMS actually developed a new type of survey for OHCQ to focus on, a new type of, which is just looking at infection controls. And so they switched their personnel to start doing that, and we're focusing more on that rather during this period. So starting in about March, And that's why we're seeing that decrease in total investigations completed, is because there was just that focus on those infection control types. Additionally, during the time, these restrictions started happening right around March. So we're looking about 36 weeks into fiscal 20, which is less than a full calendar year. And so because of that, OHCQ also fell short, or not only fell short rather, but regressed in looking at assisted living programs. So what we're highlighting here is that those red bars that you see, the agency is statutorily mandated to survey all assisted living programs in a year. Of course, as we mentioned, sometimes the lower levels of staffing make that challenging. And then this year on top of that, because they really were only able to do their work in the first 3 quarters of the year, that number ends up being lower than they were in 19, where previously you can see a lot of progress was made by the agency. And then also now looking at developmental disability facilities, they actually were able to survey the same number in 19 and 20 as in 19. Of course, again, these were limited by what they could do and where they could go into these facilities. And so we would anticipate with both of these, the agency would have made progress given the trajectory they were on. However, of course, they were unable to, given that they couldn't do surveys for the back half of fiscal 20. Ultimately, DLS is concurring with the governor's allowance here, and that concludes my presentation, and I'd be happy to take any questions.
Thank you. Are there any questions for Andrew Garrison? Senator Young?
Yeah, you brought it. Well, first off, are you adding anything to the budget this year for long-term care facilities in terms of doing these inspections and fulfilling their mandates? And as part of that, I've had a lot of experience with these facilities lately because of family in them. If these, I think one of the reasons that we've had a lot of problems with COVID in these homes is they hire very low paid people that go in and out and aren't well trained. If they can go in and out, don't we have the power to say our inspectors can go in?
Thank you for the question, Senator. So what we're showing here in Exhibit 3 is some additional staff that has been added to the budget this year. And those are driving the increases that we're seeing, as well as where they're putting them is in these units, particularly long-term care units, the one that's focused on those nursing home inspections. So we are on track with what has been outlined to hopefully get them to be meeting those survey goals. With regards to being able to investigate and be doing some of those surveys, I'm going to let the agency expand a little bit further on what they have been able to do. But in my discussions with the department, they have been keeping busy and doing as much as they can remotely or off-site, but really are trying to limit both of their staff from going in and possibly exposing themselves to these facilities or bringing in anything from there. And of course, there were separate actions taken by the department to look at testing of nursing home staff to try to limit some of these exposures that we've seen. And that's, I think, in part responsible for some of that leveling off that I was showing here in Exhibit 5 that happened from late summer into, I guess, early fall.
I guess related to that, wouldn't the lack of inspections be part of the problem of the COVID problem we've had there, because we aren't checking the facilities, we aren't checking their procedures with their employees? It seems like it would be time to step up inspections, not back away from them.
So the inspections that were being done, particularly with regards to nursing homes, were ones that were able to investigate complaints, particularly regarding infection control. And then I can let OHCQ again expand a little bit more on exactly what that looked like from a process standpoint, but that still certainly was a focus of some of these. The other inspections and surveys we look at are generally much more broad as well than what they were actually able to do, given some of the safety restraints that were put in place.
Okay, I guess.
Yeah, Senator, some of those questions you may want to hold to or re-ask when we have the secretary and his panel up. I have Delegate Henson and then the subcommittee vice chair.
Thank you, Madam Chair. Thank you, Andrew, for the detailed presentation. If I may be permitted, I have 3 questions. One of them is there anything in the budget that speaks to advancing our nursing homes, our congregate care facilities in terms of technology? We know that inspections and keeping that process going over a pandemic, there is some ability to do it virtually. Also experience some challenges with persons being able to stay connected to their loved ones, having access to, video conferencing or telephone methods to stay connected. Does anything in the budget upgrade them or bring them to a place technologically where we could be able to engage some features like that?
Not that I'm aware of, and particularly not in this budget. What OGQ really does is the regulatory aspect of a lot of these homes. MDH might know more broadly if there has been funding that's able to be allocated directly to these providers to increase their technology capacity there. But if there is, it wouldn't necessarily be here.
Thank you. I'll ask the department as well. I know that some of our nursing homes indicated they applied for grant funding to be able to do so, and I'm not sure to what place to look for that in our budget. With regard to visits, it's my understanding that with a number of our facilities, hospitals and other related institutions is how the Health General article has it now, that access to loved ones for visits is a feature of receiving the Medicaid funds and receiving federal subsidies, but that this office does the inspecting to make sure that quality is maintained across the board. And that being just one feature of quality is what's in our Medicaid budget to a patient bill of rights that says that people have the right to have their visits done. Do we know to what extent the ability to provide oversight there has been done or how that's reflected in the budget?
I don't know about the oversight component, particularly with regards to visits. Again, that might be something that OHCQ might be better able to address as to when visitors were able to come in and what that looked like from a regulatory standpoint.
Thank you, Mr. Garrison. And then my third and final question is, a number of the budgets that we've looked at have been based on enrollment projections, and a lot of projections for certain benefits programs are down this year, or maybe, reflecting, I believe that the budgets are based on the historic levels of what's happened in those agencies, and some of them taking advantage of some recent shifts and changes. It's my understanding that in this particular industry that we've seen some enrollment decline in our congregate care living facilities. Does the budget reflect a staff that's adequate to provide oversight at the levels that they were historically, or where we are now and where we believe we might be in the future?
So from the staffing concerns, I think we're still building up to a level that would be adequate for the current capacity in the state. The surveys are really on a facility and building level and less of a resident census level. And given that OHCQ in particular continues to receive staffing, I think we would still believe that they're understaffed even for the current sort of baseline capacity that we have in the state.
Thank you, Mr. Garrison. Thank you, Madam Chair.
Thank you. We'll go to Vice Chair Valentino Smith.
Thank you, Madam Chair. Thank you, Mr. Garrison. Just in terms of getting us information back, of course, we're dismayed to hear that Maryland has a higher than average rate for deaths in these facilities. And in your chart on page 7, it's correct that you're showing 40 deaths from staff in these facilities. And if you could help us get an understanding of where those staff were working and the types of staff that they were, I think that would be certainly helpful to us. And then in your analysis, you talked about the emergency order for twice weekly testing for all staff in Maryland nursing homes and weekly testing for residents. Is that order still in place, or is that something they're still following? We could ask the secretary, but I thought you might know.
I don't want to speak out there. I believe the secretary would have a better idea as to which has been in order currently. There's been several amendments to these various orders, and I don't know which one's currently in place.
No, that's fine. We'll be able to ask the secretary. Thank you for your analysis. Thank you, Madam Chair.
Thank you. Any further questions for Mr. Garrison? All right, seeing none, thank you again for that analysis. We're now going to hear from the Honorable Dennis Schrader, Acting Secretary of Health. And Mr. Secretary and your panel, you have the floor.
Thank you, Madam Chair and members of the Joint Committee. I have with me today Deputy Secretary Chan and Dr. Tricia Ney, who is the individual who runs Office of Healthcare Quality. We have no disagreement with the report from the analysts, and we're available to answer any questions. I also have Jordan Butler with us, who is our CFO.
Okay, thank you, Mr. Secretary. So members, Mr. Secretary, I take it you didn't have any overview remarks. You're open to questions?
Yes, Madam Chair, we're open to questions. Thank you. No opening remarks.
Okay. So questions from the members? Senator Young.
Couple of questions. I think Senate Bill 204 has added regulations for memory care units at assisted living facilities. I understand there's somewhere around 1,600 of these in the state. How many of those, how many memory care units roughly would have added help from these regulations at these 1,600 units?
Yes, Senator, we'll have to take that question and get back to you, sir. We're prepared to answer that today.
Okay. You don't know whether they're going to large units or small units? I guess first off, you don't know how many there are. That's what I'd like to know. And then where the help's going to go. But if you get back to that, that's great. But question I asked just a minute ago that I'll ask again. Inspections related to these units because of COVID. How many new people are you adding to do these inspections? And the other part of the question I was asking is, it sounded like we were not doing as many inspections because of COVID. And I would have thought that would have been a time we would have done more. What's your response to that?
So for the first part of your question, sir, I'm going to ask Dr. Ney to respond, and then we'll take your second question. Go ahead, Dr. Ney.
Thank you, Secretary. So as far as the focused infection control survey that was mentioned earlier, that we've done 426 of those to date. We've been in every Maryland nursing home by August 17th, looking at that on site and looking at that. So we never completely stopped surveying. CMS changed what kind of surveys we went on site to do, but we never completely stopped. So we continue to do those each and every day, weekday out in the field.
What percentage? You said 416. What percentage is that of?
There are 227 nursing homes, Senator. So we've been in every nursing home once, and some nursing homes as many as 3 times. So the process is that CMS actually will flag the nursing homes with increased outbreaks or increased infection control concerns, and those are the facilities we report to unannounced to do the surveys.
Okay.
And Senator, if I could follow up on your second question, although the inspections were down, we organized response teams to go into the nursing homes on a regular cycle. In the spring, during the first wave, we had a team led by the National Guard, and that's when we started the the testing program to make sure residents and staff were being tested. When the first wave ended through the summer and the outbreak situation at the nursing homes leveled out, we then formed regular response teams to go into the nursing homes on a regular cycle as we were tracking the outbreaks. So it was very important to be able to get the trust of the industry to not have them perceive our intervention as being regulatory. So we've had every several weeks on a cycle, we track all the nursing home outbreaks. We have people going in doing infection control surveys and what we're calling technical assistance teams, so that we would help the nursing homes figure out how to make sure they protect both their staff and their individuals, in addition to the heightened testing that we did in August and into the fall. Although the regulatory mission was at a lower level, the intervention teams were very aggressive, and because we had built a trust with the nursing homes, they allowed us in. They didn't have to allow us in, quite frankly, but they do, and that mission has been very successful. We also linked up the nursing homes with various hospitals. We had because one of the things that we've learned through all this, and this is an accreditation issue that after all this is over should be taken up. The nursing homes are not as sophisticated at infection control as hospitals are, quite frankly. And that's why we're leaning forward and intervening into those nursing homes on a regular basis. We track every one of them on a set of 12 factors, and when an outbreak gets to a certain level, if we need to actually do bridging operations, which means we'll send people in to cover for their staff, we do that also. So I think that's the answer to your second question, sir.
Okay, if I could, just one quick comment, and then I'm through. I know it's a really tough balance. We've got the physical health to worry about, but the mental health of these people that are locked in the facilities. I know of some people that have just said, I want to die. I can't see anybody. I'm lonely. And I know some were pulled out because of this. I just hope if this continues, you can really try to take a look at the balance of the mental and the physical, because it's really, really tough on these old people when they can't see family or things. You don't have to answer that. I know it's tough and you've looked at it. Just please look at it harder.
Yeah, Senator Young, we agree with you, and that's why we did change some of our orders to allow compassionate care. It's a very difficult balance, as you said, between protecting them physically, but understanding that in protecting them physically, their mental health status is, in a different place. So it's a heart-wrenching decision, but I think we've erred on the side of protecting them physically because we don't want people dying in our nursing homes from the virus. But I do hear you loud and clear.
And the changes you made did help. So thank you.
Thank you,
Yes,
Senator Young. Thank you, Mr. Secretary. Okay, and members, I apologize. I was doing the hand raise thing out of order because I had some of mine blocked. So I just figured out I needed to scroll up. So now I'm going to go to Delegate Henson, then Vice Chair Valentino Smith, then Delegate Young.
Thank you, Madam Chair, and thank you, Mr. Acting Secretary. My questions are the same two questions that I posed to Mr. Garrison. If I can get some clarity on what, if anything, in the budget reflects bringing the department up to being technically savvy, or being at the place where we can maybe engage in some alternate forms of staying in communication with our facilities while we're in a space where being able to go in on site is not safe. And then my second question, if I may just pose them at the same time for the sake of time, is with the right to visits. And Senator Young touched on that as well, that keeping that connection between a person and their loved ones is certainly paramount, particularly at times like this. The agency's responsibility to inspect and to maintain oversight there. To what capacity are we looking into persons' rights to visits and making sure that that is being upheld as well with the other regulatory things that we're inspecting and checking for?
Yes, thank you, Delegate. So I did fail to mention initially that we are also guided by CMS regulations because much of the nursing home industry is paid for by Medicaid. So our actions track very closely with their guidance. Sometimes we have to interpret it. We've had for example, with the testing and also with the visitation policies. And there's no simple answer to those, but we are not making it up as we go. We are using CMS guidance to guide us. I think if I understood your first question, we have a plan in place that's a multi-year plan to add more staff to OHCQ, and this year we're adding another 10, and we've been doing this over the last couple of years to add additional people. In terms of how we're actually continuing the oversight mission, I'd have to defer. I don't know, Dr. Ney, if you could help with that question. I think you're in a better position to answer that part of the delegate's question.
Certainly, Secretary. Delegate Henson, I'll answer that twofold. First, all of my surveyors, there are approximately 150 of them, have laptop computers that have the ability to do video surveys and video calls as needed, as well as smartphones. As far as federal and state law allowed us to do, we did offsite investigations of things we didn't need to be on site for as far as the federal and state law allowed. So for instance, if it was a life safety code issue, we could use the video system to look at that rather than going on site to the nursing home. So we already have adapted all those processes, and we started doing that actually in late March of 2020 for looking at new sites ready to open to get them up and running. Secondly, as far as technology for the nursing homes, there is an expedited process for nursing homes to get a set amount of money to use for technology for communication. So our full-time grants person in my office reached out to every single nursing home. The vast majority took advantage of that money. And the process was very simple, and usually within days, not weeks, they were able to get that money for that technology.
Thank you, Madam Chair. Thank you to the department as well.
Thank you. Vice Chair Valentino Smith.
Thank you, Madam Chair, and thank you, Mr. Secretary. It's very busy and difficult, challenging times. Two questions. Just perplexed. I know that you've got a dashboard on the state website for nursing homes, and certainly it was very helpful when you were requested to put up by facility the number of deaths and staff reports. But staff and Mr. Garrison are briefing us on numbers in Exhibit 4 that are really not close to the numbers that are on the dashboard for the website. So your website showing 28 staff deaths, and Mr. Garrison's talking to us about 40. Somewhere in between in the next week or two, can we just get kind of confirmation on the number of staff deaths and a little bit more update on the type of staff? And then in terms of PPE for these facilities, does your department, I know that it was explained to us in our PPE briefing that you have this command central station headquarters set up and people funnel in their requests for PPE. So are you still just taking individual requests from each of the facilities for the amount of PPE they need, or are you sending it out to the facilities based on a formula for what they need? And are you still doing the testing how often are you testing staff and how often are you testing residents?
So, okay, let's start with the PPE. We have a state stockpile of PPE, which is, based on the burn rate estimates, is about between 30 and 60 days, depending on the commodity. In some cases, more than 60 days. We feed also stockpiles, part of that stockpile, into the local health departments. And we also, with these response teams, the technical assistance teams that go in, we monitor, and they have to self-report the amount of PPE they have on a daily basis. So we're tracking that. We do require them to buy their own PPE since they are private businesses. However, they have access to the local health department's cache of PPE if it's necessary. So we're monitoring all three levels, and we do the same thing with the hospitals. The hospitals have very robust personal protective equipment caches, and we back that up if needed, but the hospitals seem to have the ability to maintain those caches better, and part of it is because the nursing homes, as I said earlier, they're not, a hospital infection control is part of their normal business. That has not been typically with the nursing, so they don't have the infrastructure, the storage facilities, and that sort of resource to manage the PPE, so they have lower levels of PPE. But we've been pushing them, but we do expect them to maintain their own levels, and we back them up through the health departments.
So if I may, Madam Chair, Mr. Chair, then just for a minute. So it is concerning, and I know it's concerning to you, that Maryland has the highest rate of deaths in these facilities on a national average. Not just a little bit more, but a lot more than the national average. And if I'm understanding you, there's not one place yet that knows the sufficiency of these facilities to be adequately maintaining enough PPE. In other words, it's their responsibility and they can ask for help if they need it, but there's no protocol this far into it for assessing a big picture of which facilities are actually maintaining an adequate supply of PPE. It's just self-reporting.
No, that's right. So, I'm sorry, I left out one part. When we go in on a regular basis, we do a cycle every 2 or 3 weeks through all the nursing homes. We are inspecting for PPE levels. So we satisfy ourselves by physically checking when we go in. They self-report on a daily basis to the state. But in addition to that, we actually go in and check.
So can you just let us know then in the next week while we're in, if facilities are not meeting their PPE needs, or we to then infer that every facility is getting 100% of the PPE they need, either in the private market or through the public market? Because it's just...
We could check that for you, yes. We'll get you some data around that.
And then how, are you still testing all the residents, staff twice a week and residents once a week in all these facilities?
We're requiring them to continue to do testing. We're also, they've been getting what's changed is the point of care testing, which is these also known as antigen tests. So they're actually doing that, and then they're following up with PCR testing to confirm positives. And they're continuing to do that for staff and residents as we continue.
Required twice a week? Is that required twice a week?
It varies depending on the nursing home. They decide, we give them options. Dr. Chan, did you want to add to that?
Yes, and it also varies. Again, this is something that we are tracking with the CMS guidance for these facilities. And so similar to visitation, there is recommendations on the frequency of testing, and it's based on the positivity of the surrounding jurisdictions in which the nursing home is.
So are you monitoring that weekly to make sure that each facility is doing the appropriate amount of testing for staff and residents according to the federal guidelines?
Yes, as we are going in with the technical assistance team and also monitoring the testing results that are being reported, we're providing that kind of monitoring as well. We are in communication with most of the nursing homes every single week and even daily.
And so as part of at least the dashboard of the database, I think for public transparency, you need to keep us posted, please, on what facilities are in compliance or not with testing requirements. Thank you.
Thank you, Delegate, and thank you to our panel. We're going to turn our last question from this panel is Delegate Young.
Thank you, Madam Chair. This question's for Dr. Ney. Hopefully just simple. It was brought up earlier about the number of long-term care facilities in the state. We're at 1,700. 1,700 long-term care facilities in the state of Maryland. Dr. Day.
Delegate Young, there are 227 nursing homes and there is 1,672 assisted living facilities. You sometimes hear the term congregate care facilities. That's not a licensure category for me. That would be a combination of long-term care, assisted living, and certain types of group homes.
Gotcha. And in terms of the folks providing long-term care, that I'm trying to get a number of facilities that offer memory care or have a unit that deals with memory care out of the facilities that you have on your books.
The last time I looked at that number, which was about 2 weeks ago, there were 88 Alzheimer's or special care units within those assisted living facilities.
Got it. So they're part of other facilities. Can you tell me whether they're larger, smaller facilities? Generally.
It ranges. I'm going to guess that it would tend to be medium or larger size, but it could be any size facility that met those requirements.
And mainly because there's no facility that's just offering memory care. It's usually a facility that's offering other services and memory care as a unit or service. Is that accurate?
I believe so. I would also think there might be a handful of facilities that do all dementia care within those assisted living programs.
Gotcha. Maybe we can follow up after this hearing too, and maybe get some of those numbers in terms of those 88 and how big the facilities are that are providing those care models. And just one thing before I go, and I appreciate it, Madam Chair, been on the committee for about 7 years. Usually the annual reports have helped with informing the DLS reports that we get. I hadn't seen the annual report yet. If it's ready to go, or if it's maybe I missed it, if you could send that to me, maybe the members of the committee, that'd be helpful for 2020.
Sure. Delegate Young, this is Webster Yee on behalf of the Department of Health. That annual report is still under review. We'll get it to you as soon as it's out.
Great. And again, I appreciate that, Webster. I know it usually comes out around November, December. Is you thinking like this month or next month? Because now we're into February.
As soon as we can, sir. Unfortunately, reports usually occupy a huge chunk of our fall, and we've been a little bit distracted, sir.
Sure have. Appreciate it, guys. Thank you, Madam Chair, Mr. Chairman.
Thank you. Thank you all for your questions. Thank you to the panel for your answers. That concludes the hearing on the budget for Maryland Department of Health, Office of Healthcare Quality. We're now going to move to the Maryland Department of Health, Public Health Administration. Ms. Wagner.
All right, thank you very much, Madam Chair. Let me just share my screen and I'll walk through that analysis with you all. Can you see it? So let's see. So this is the analysis for the Public Health Administration. This is the offices under Department of Health's Public Health Services, except for the Prevention and Health Promotion Administration, which will be covered in a hearing next Monday, actually. So jumping right in on this first chart, you can see that the Public Health Administration's budget was significantly increased by COVID-19 spending in fiscal 20. And then you can see it was impacted by COVID-19 appropriations to a lesser extent in fiscal 21. In fiscal 20, though, about $1.2 billion was added to the Office of Preparedness and Response. We discussed this in more detail in the MDH overview analysis, but here is where you're seeing a lot of the state's coronavirus relief funds actually being appropriated. And then you're also seeing this bar at the top here is COVID-19 spending that is being reimbursed by FEMA. And I'll note here that the budget assumed a 75% reimbursement rate from FEMA, but recently the Biden administration announced that it would make 100% reimbursements, and that would be retroactive to January of 2020. So the department now estimates that that change will give the state about $114 million more in additional funds that will backfill that 25% match the department had planned. In terms of the fiscal 22 budget as introduced, you can see that the spending returns to more typical levels for this department. And again, the budget doesn't currently reflect any of the December stimulus funding or other federal aid that we would expect to be added later on. So this is highly unlikely to be how the budget looks at the end of the fiscal year. So then going on to look at the change in fiscal 22, PHA shows a large drop in spending in the allowance, and that's mostly due to proposed deficiencies that would add COVID-19 related personnel costs in fiscal 22 and that, or excuse me, 21, and that would be backfilling general funds in other agencies, and so that's driving the $245 million decrease in spending in PHA. To highlight a few other changes in this department, the Maryland Loan Assistance Repayment Program, or MLARP, for physicians and physician assistants was transferred from the Maryland Higher Education Commission to the Office of Population Health Improvement. And that was part of legislation passed last session. That bill also mandated that if the governor did not add $1 million in special funds from the Board of Physicians Fund to the MLARP program, then the comptroller would be mandated to distribute the difference in special funds. And so for this program, the special fund appropriation decreases from $790,000 in fiscal 21 to $400,000 in special funds in fiscal 22. And that would mean that the comptroller will be required to distribute the remaining $600,000 from the Board of Physicians fees. And then another action is that there's a proposed BRFA action that would reduce $500,000 in general funds from the Office of Controlled Substances Administration, and then would transfer $500,000 in special funds from the Board of Pharmacists Fund to backfill that general fund reduction. There's a recommendation in the Health Boards and Commissions analysis that would reject this special fund transfer, and then would also reject the reduction in general funds that's proposed in the BRFA. So then moving on to the discussion of core public health services, this funding makes up about 35% of the department's budget for public health administration. And so Exhibit 3 shows recent changes in the annual allocation for local health departments based on the mandated formula. Fiscal 21 and 22 you're seeing is leveling off after an increase in fiscal 20 due to general salary increases, driving that slightly sharper increase. So in this section, we wanted to bring up two separate issues on how the mandated formula funding for local health departments is currently administered. So first, the formula and statute applies, the formula and statute applies an annual population and inflation growth factor to the statewide appropriation from the prior year. However, this hasn't been applied consistently, as fiscal 21 included general salary increases in the base, but then fiscal 20 and 22 did not include general salary increases in the base that was then inflated for the future year. The second issue we wanted to bring up is that the population and inflation factors aren't necessarily correlated with the local health department's actual growth in spending or their local public health or administrative needs. The funding formula is also just one specific source of support for local health departments or for state support for local health departments, while there are an increasing number of discretionary grants that are going to local health departments in fiscal 22. For example, $4 million in additional general funds were added to the department's Office of the Secretary budget and that would be for infrastructure needs that are not currently supported by the mandated funding formula. And then more recently, on February 4th, the administration announced that a supplemental budget would add another $9 million in general funds for local clinics that saw revenue losses in their fee-for-service programs. So these are just two examples of, in fiscal 22, discretionary grants for local health departments being created in a decentralized way outside of the funding formula. And by providing funds this way, this creates more unpredictable sources of funds, as these grant amounts can change year to year, rather than amending the core formula to create a more predictable source of additional funds. And so the Department of Legislative Services requests that MDH provide the following information on the formula, including how it intends to allocate the $4 million in general funds, and then also how the department would recommend changing the formula in the future. So then moving on to a discussion of regular personnel. The Public Health Administration across all offices show a vacancy rate of 9.1% overall, and that accounts for 38 positions. And we found it concerning that the public health vacancies remain just under 10%, although 9% in December of 2020 is an improvement over the 12% vacancy rate shown in December of 2019. And still, the DLS is asking the department to discuss how it is recruiting and retaining health professionals during the pandemic. And then DLS is recommending adopting committee narrative for a report that would provide more information on recruitment efforts across public health services and in local health departments. So then the only issue write-up in this analysis has to do with the Office of the Chief Medical Examiner. There were a number of operational and workload changes resulting from the pandemic, so we've listed them here. Just to highlight a few of these, the Office of the Chief Medical Examiner investigated more unattended deaths where COVID-19 needed to be ruled out. Most COVID-19 deaths wouldn't have been in the jurisdiction of OCME, but they did see this increase in attended deaths. And then there was also a significant increase in overdose deaths that OCME did investigate and would have to autopsy in some cases. And then in terms of PPE needs, OCME reported that local forensic investigator and body transport vendors refused to work at times due to a lack of PPE. The office began providing supplies to county investigators, but 13 transport vendors have stopped working with the state, and body transport services have seen delays, according to the office. And then switching over to OCME staffing challenges. This chart shows the ratio of autopsies conducted to the number of full-time equivalent medical examiners, and that's what this green line is showing. The black line here shows the threshold for OCME receiving full accreditation. If they have an average of more than 325 autopsies per full-time equivalent medical examiner, then the accrediting agency cannot provide full accreditation, as that's an essential requirement for chief medical examiner offices. And so you're seeing recently that OCME did see an increase in this ratio with more medical examiners performing more autopsies overall. This is driven by some of those pandemic impacts I discussed. The yellow bars show changes in the number of examinations, and then the blue bars show the percent change in the number of medical examiners working for the department. And so that's just showing that recently this ratio has increased, but it hasn't quite gone above the threshold. So they are still remaining below that essential requirement. And then the last staffing note I'll make is that at the end of December 2019, the former chief medical examiner retired, and a deputy chief medical examiner left shortly after that. And so we asked the department to provide an update on the recruitment effort for these positions. Other than that, you can see the recommended action for that report on regular personnel in public health. But with that, that concludes my presentation. Thank you.
Thank you for that analysis. Are there any questions from the members? Okay, I'm looking for blue hands and raised hands. I don't see any. Right, thank you, Ms. Wagner. We will turn to the panel with our acting secretary. Mr. Secretary, you can either give remarks if you like, respond to the analyst. I know you've provided some written remarks.
Yeah, thank you, Madam Chair and committee members. I want to just make two thoughts, and then I'm going to turn it over to Dr. Chan. One is that Secretary Neal and myself over the last few years have been very committed to bringing more resources to our local health departments. As many may or may not know, during the recession back in 2008 and 2009, the local health departments took a severe cut, and we have been trying to systematically bring those numbers back. They have not necessarily kept pace with inflation, but we are bringing those numbers back. So we're very pleased to have this year's $4 million, and I'll let Dr. Chan talk about the details of that. The other thing is I wanted to introduce Dr. Chan, who's with us, as well as Atif Chowdhury, who's our Deputy Secretary for Operations. He'll be able to address any questions about the roof. And we've got Jordan Butler, again, our CFO. And as I turn it over to Dr. Chan, who's our Acting Deputy Secretary, I wanted to thank her. She has been working tirelessly throughout this process and is to be commended for her heroic work. And so, Dr. Chan, I'll turn it over to you.
Thank you.
Thank you, Secretary Schrader, and thank you, Chairwoman, and to members of the committee. We are here to answer questions. I will comment that, our local health departments are our partner always, not only in this COVID pandemic, but throughout, every day on a number of public health issues that go beyond COVID in terms of environmental health, maternal and child health, and other support services, and they have continued those efforts even despite the pandemic. And so the dollars that we are requesting as part of our supplemental budget is to continue to support that infrastructure within local health, whether it's because of COVID that there is a need, but also to support other infrastructure, including information technology, staffing, and some of the revenue shortfalls that we have seen during the past 12 months or so. So want to encourage you to consider this as something that is important for us to sustain infrastructure within local health departments, who are an incredibly important partner for us. So I will stop there, and I don't know if Mr. Butler would like to address some of the other questions
Maybe we should turn it back to Chair Griffith and see if there are any questions from the panel. That's all we have to offer today, Madam Chair.
Thank you, and your team. Let me pause and see if the members have any questions before I make a comment. Delegate Henson.
Thank you, Madam Chair, and forgive me if I have this wrong. I believe this is the budget where we can ask some questions about the vaccine distribution, that it would be the office that's handling that. Do I have that correct, Mr. Acting Secretary?
Yes, absolutely.
Thank you. I know that the budget analysis did some probing into the algorithm or the method used for distributing funds to local health departments. And it looks like we might be asking for some additional information to help us understand that process better. Can you help us understand the process as it relates to the vaccine allocation going to the local health departments? I guess my question there is twofold. Is one, understanding the allocations that are made to individual counties, understanding that how you factored that. And then the second would be understanding the public and private partnership. When we see the vaccines distributed to our private partners versus our county health departments, understanding that decision-making process a little better as well.
Right. So let me start with your first question. As we do the allocations, we have a formula that tracks the county's allocation on doses per thousand, and we look at it in the aggregate, so that whether it's a hospital or a local health department or a private pharmacy or a provider like Kaiser Permanente, we provide that to them, and we are building an infrastructure so that as the doses that we are able to get from the federal government increase, we will have more channels. So we're measuring on that basis. So we're looking at two factors. One is speed, and the other is equity. And we want to make sure we're getting those shots in arms as fast as possible. Today's data shows that about 85% of the first doses that have pushed out to providers have been delivered. And today is Monday. Usually the new doses go out on Tuesday and Wednesday. So we're tracking at a very high level of doses given. But we want to continue to grow those distribution channels. We're also following President Biden's preferred method of doing this. Very shortly, as you probably have heard, the federal government is going to be ramping up a major program starting next week on the 11th to push major quantities of vaccine to pharmacies in the community. Those allocations will go direct to the pharmacies. They won't affect our allocation, and we will continue to use our resources to reach into the community to reach the vulnerable and hard to reach populations. But the federal government's strategy will be to drive doses on a very large scale to private pharmacies in the state.
Thank you, Mr. Acting Secretary. If I'm understanding it correct, what you're saying is that the decision-making for vaccine allocations that go to our private partners and to our counties is being driven by federal policy? Well,
I didn't exactly say it that way. Let me back up a step. There's two pharmacy programs. One is a transfer program. The other is a retail pharmacy program. The retail pharmacy program, which is starting next week, which is going to drive large quantities, will go from the federal government to the pharmacies. The transfer program is another federal program that allows us to transfer doses to other pharmacies in the state, and we're giving those pharmacies small quantities for now just to get them up and running. If you look at the total distribution or the total allocation, as of last week, 40% were going to the hospitals, 34% were going to the local health departments, and another 16% was going to the CVS and Walgreens federal. That was a federal contract, which is also federal policy, yes. So it's a mix of the two. We get about 88,000 doses per week right now. We had been getting 72,000, and the Biden administration gave us a 16% increase. That took it up to 82,000. This is the second week that we'll be getting the 82,000. So it's a mix, but it's all consistent with we're aligned with the federal policies.
Thank you. If I may be permitted one additional question?
Yes, briefly, because we do have another question, and I know you all have to be on the floor, but yeah, one more.
Thank you, Madam Chair. I apologize. It's my understanding that our health department here in Anne Arundel County has expressed some satisfaction with the dosage allotment to the counties. And I want to make sure that I understand exactly what you're saying about how those decisions are being made, that it's being made on a pro rata basis based on the number of people you have in your county, just by volume. But then there's also some additional factors that are going into that decision making. You mentioned equity. Could you help me understand those additional factors that are going in as well?
Well, equity, we break equity down into two pieces. One is demographics, and the other is per capita. And up here to 4, we've been looking very carefully to make sure that the doses per 1,000 are being distributed equitably to all channels, which would include hospitals, local health departments, and the private partners. We are going to be moving in a direction, since we've appointed Brigadier General Burkhead as the head of our equity task force. We are going to be drilling into the data at a granular level around the equity based on demographics, and that'll be informing our decisions going forward, as well as the per capita. Heretofore, it's been mostly per capita over the first 8 weeks. Actually, we're in our 9th week.
Thank you.
All right, thank you. Thank you, Delegate. All right, Delegate Young.
Thank you, Madam Chair. Appreciate the information, Ms. Secretary. And I wanted to, we don't need to get into the weeds about the formula that's being used to determine which jurisdiction gets how much. But I am curious, now that there's a statewide mandate that all schools have to be open by March 1st, have teachers or numbers of teachers that need to be vaccinated been included into your metrics, or is that a consideration that's not being requested or being used whatsoever?
So we have another spreadsheet that I don't have with me right at this minute, and the committee probably doesn't have time, but we can get that to you. Is that right now there are within phase 1, A, B, and C, there are 2 million eligible folks to receive the vaccine. At 50% uptake meaning the number of people that are willing to take the vaccine, we're estimating there's about a million people who are willing at this moment. That could change, but that's been our experience so far. And and we now have upwards of 700,000 doses. So each week we're systematically growing the number of vaccines. Within that 2 million, within 1B are teachers. And so we're asking jurisdictions to tier their doses to get folks who are 75 plus, 65 plus, and then some of these critical categories like teachers. We also understand that it's going to be a few more weeks before we have enough doses to get everybody.
I understand. I appreciate that. And I also want to clarify, if you had the doses, you'd get them where they need to go. Everybody is trying to vaccinate as many folks as possible. I just want to make sure that there's a mandate related to opening all schools by March 1st, that we're taking into consideration the teachers that need to be vaccinated to then educate safely and appropriately. Thank you, Mr. Secretary. Thank you, Madam Chair.
Thank you. And Mr. Secretary, and to your panel, I know in the interest of time, remarks can be very brief, and if necessary, happy to follow up online or offline. Just wanted to thank you, Dr. Chan, and you, Mr. Secretary, and all of you for your work trying to support local health departments and provide some predictability to their funding. As you know, some of us, I think might be the House Chair and I are putting in a piece of legislation to help strengthen funding for local health departments. And I think it's been amplified, the need during this crisis. So would certainly love to have you take a look at that and let us know your thoughts on that. I am concerned about the accreditation, and you mentioned, Mr. Secretary, in your opening remarks, a quick update on the roof. I know you all have been doing everything you can to get the staffing of the medical examiner's office and the leadership in place. So any updates you have around that and how we're looking in that regard would be appreciated.
Yes, I'll ask Dr. Chan to speak to the recruitment, and then Chief Chowdhury could give a very brief update on the roof. Go ahead, Deputy Secretary.
Thank you, Madam Chair. And so we have been working very closely with the Postmortem Commission on the recruitment for the permanent Chief Medical Examiner, and we will be able to make an announcement shortly on the selection. This is a candidate who has a long history in serving in various state medical examiner offices, and is well known and well respected. And so we are looking forward to being able to make that announcement in the very, very near future. In addition, as you may be aware, there has been a recent increase in the salary available for the assistant medical examiners, and we believe that that will improve our ability to hire and retain these critical staff. And we have heard initially from our Office of Human Resources that there appears to be more interest in these positions, and so we look forward to that being able to stabilize some of the staffing in the Chief Medical Examiner's office. So,
Deputy Secretary Chowdhury, could you give a very brief update on the roof?
Yeah, thank you, Mr. Secretary. Madam Chair, just wanted to provide a quick update. The funding has been allocated for this particular project. It is a little over $2.5 million. It has been approved by the Board of Public Works in November of 2020. It is a full roof replacement with parapet. We've already had pre-construction meetings on site there to get the project geared up. It is beginning this month and will ramp up very quickly. Roof replacement projects such as this, generally speaking, are very difficult to do in the winter. So we're gearing up to do this now to do a full replacement, which will proceed over and looking to be done this year, later this year, probably by September it will be completed.
Thank you. So the timing of that is consistent with the expectations of those who are waiting for us to get that completed for the accreditation process?
Yes, and generally speaking, they just want to know that we have a plan in place and they wanted to have general updates on our progress. And as long as we're showing progress and it's in place and funding's been allocated, generally they allow exceptions to extensions if needed.
Okay, thank you very much. Thank you, and please keep us posted as things get completed. We will celebrate along with you. All right.
Thank you very much.
Thank you, Mr. Secretary. Anything before we close your budget hearing?
No, ma'am. Thank you very much.
Okay, well, members, seeing no further questions, that concludes the hearing on the Public Health Administration budget. Thank you all. Thank you all very much. We're going to move to DHS Office of Home Energy Programs. Ms. Zimmerman.
Yes. The Office of Home Energy Programs budget increases by $12 million or about 9%. That is primarily almost exclusively due to available special funds from the Strategic Energy Investment Fund due to available fund balance and revenue attained from a prior year. However, the fiscal 2021 appropriation does not yet include $19.4 million, which is the state's share of the additional LIHEAP or federal low-income home energy assistance program funds that were appropriated in the CARES Act. When you take that into account, the budget would decrease by about $7 million. Exhibit 1 provides some information on the recent history of energy assistance applications and benefits provision. What you can see here is that applications, which have been generally declining but had been more steady in recent years, decreased substantially in fiscal 2020. This decrease is unusual, as typically high unemployment and high energy use, both of which were experienced as a result of the pandemic, would lead to increases in applications. What basically happened was that when the utility termination moratorium went into effect in the middle of March and continued till November 15th, people didn't apply at the same rate. DHS indicates that about half of applications are accompanied by a termination notice. So without the termination notice, fewer people applied. Consistent with that, the number of households receiving bill payment assistance benefits decreased by 8% for the heating program and 10% for the electric program. That was the largest decrease in the program history. While applications didn't necessarily decrease for the arrearage assistance programs, the households receiving benefits did. This shows information on the applications and benefits provided to date. So consistent with what happened at the end of fiscal 2020, at the beginning of fiscal 2021, applications remained lower than the prior year level. However, as we approach the end of the utility termination moratorium, more households began applying, and it now exceeds the number of applications at this point last year. For the bill payment assistance program, this was still relatively modest of an increase. The households receiving benefits are still down fairly substantially due to the timing of the applications and the application processing times. The arrearage assistance programs, however, have seen substantial increases in the number of households applying for the benefit. However, again, the households receiving the benefit are still down significantly. In terms of the average benefit, the notable things here are that the average arrearage assistance benefits have increased, particularly for the electric program, nearly a 19% increase, over a $140 increase. At the level of average benefit that we've experienced through December, that's the highest it's been since fiscal 2016, when the bill payment benefits were considerably lower than they are now. But this is consistent with utility reported data that indicates that arrearages per customer with arrears have doubled across most of the larger utilities. Overall, spending is down by about 29% year to date. We expect that will reverse as more applications continue to be processed. And we've asked the agency to comment on efforts by the local administrating agencies to ensure households receive benefits prior to termination, and ask them to comment on how they monitor spending to ensure that they have enough available funds to meet the need. If we move ahead to Exhibit 6 here, this presents information on the agency's spending. I think just the most notable thing is about 90% of the spending in the budget is dedicated to energy assistance benefits. Most of that, more than half of that, is for the heating assistance program, and the remainder for the electric programs, which are the USP and the CEF funding sources. Of those, of the electric sources, the Strategic Energy Investment Fund is what drives the budgetary change. Exhibit 7 presents the information on the changes in the budget. Again, outside of the change in funding for the energy assistance benefit, the only really notable change here is a decrease in the funding that relates to the abolition of 1.37 long-term vacant positions, which is about a $50,000 decrease. So moving ahead to a discussion of some of the individual funding sources, the Strategic Energy Investment Fund, under state law, the Energy Assistance Program receives 50% of the revenue from the Regional Greenhouse Gas Initiative carbon dioxide emission allowance auctions. The revenue varies substantially. It can be as low as the minimum clearing price or significantly higher. Recently, it's been relatively stable and has even increased in the most recent auctions. These changes have occurred due to changes in the program that were announced and are about to go into effect, and an additional state joining. More information about that is in the Maryland Energy Administration analysis. However, the unpredictability of the revenue led to some changes in how the Maryland Energy Administration, which is the administrator of the fund, forecast revenue for the budget. Because this has led to the unpredictability, led to fund balance increases and mid-year program reductions. So they were trying to avoid those kinds of situations. So they budget at the lowest possible level and then use kind of the extra money they might get over that in each auction towards a future budget cycle. So the fiscal 2020 kind of overattainment over that minimum is used in fiscal 2022. That results in a buildup of balance and also delays the impact of any kind of increase in revenue that we're seeing in the recent auction revenue. But it ensures that there's kind of a stable funding level each year, and you know that you have the money in hand. So the fiscal 22 allowance assumes the availability of some of that fund balance and some of that overattainment that we've already received, and is drawing down some of the fund balance. So it allows us to spend more money than we have in the past. I would apologize in this exhibit that these bottom two lines are the 22 estimated balance, not the 2021 estimated balance. So as you can see, they would still be expected to have about $14.3 million of fund balance. Under current law, there is a departmental bill that would reduce that some, but they would still have a substantial fund balance available despite the increase this year to support future year funding. The only notable item here is, again, the abolition of the 1.37 vacant positions. So moving on to the issues, the primary issue here is about application denial rates. Last year in the Joint Chairman's report, you requested some information on the application denial rates and the reason for denial and what steps they're taking to reduce those denial rates. Exhibit 10 presents the information by benefit type. So the blue dotted line and the red line with the triangles are the two bill payment assistance programs. And you can see that they've been on a relatively steady increase since fiscal 2014. They increased by 2 percentage points in fiscal 2020, both of them over 30%. The arrearage assistance programs did come down, have fairly substantial decreases, nearly 10 percentage points for the electric arrearage assistance program, a little higher for the gas arrearage assistance program. It was only in its second year. However, despite the decrease, the electric arrearage assistance program, like the bill payment programs, remains well above the levels that they were in fiscal 2014. While it appears that there is a decrease in fiscal 2021, this data is from earlier in the fiscal year when there had been fewer applications, and it excludes data for applications that were still subject to being overturned. So there's still some caution about whether that decrease is likely to continue. Exhibit 11 presents information on the reason for denial. So the light blue bar is missing documentation. That accounts for more than 65% of denials among each of the benefit types. The remaining denials for the bill payment assistance programs are almost exclusively due to income that's over the limit. For the arrearage programs, there's a limitation on receiving the benefit once every 7 years, and that accounts for about 7% of the EUSP arrearages and 5% for the gas arrearages. They have taken, or they indicated they've taken a number of steps to reduce the denial rates. And that includes in fiscal 2019, modifying a number of requirements in terms of the documents that you're allowed to use to prove for verification, for identification, residency, and adopting a policy to exempt certain people from having to provide a certain portion of the data. They also modified their mailing system so that some of the documents you might need for verification to have information for will come with you with the notice that you need to provide it. Another aspect that they indicated might assist with reducing the application denial rates is implementing categorical eligibility and integrating the system into the new eligibility and enrollment system that's part of the larger public assistance benefit system that is planned to be rolled out. This integration would occur in July 2022. So under categorical eligibility, which they expect would happen at the same time, a household's eligibility for another program can be used to determine the eligibility for energy assistance benefits. That would likely reduce the number of verifications you need to process applications and therefore denial rates. DHS had contracted with a vendor to study what that would mean for the program in terms of administrative costs and the percent of households served. They received that report in March 2020. They looked at, the vendor looked at the number of states with categorical eligibility. There were about 20 states along with the District of Columbia. The states primarily used SNAP eligibility for the categorical eligibility. Some used the temporary assistance for needy families or other programs as well. They also looked at the service delivery method, which is, so in Maryland, we use kind of a combination delivery method with some of the delivery happening through in some jurisdictions with the community action agencies and some at the local departments of social services. And in 2 jurisdictions, it's a local government, a different local government office.
If I can interrupt for a minute, I apologize. The House bells have just rung and the House has about 7 minutes to get to the floor for our first floor session this session. So the House members will be dropping off. But please continue and we will circle back on the next hearing. Thank you.
And thank you. And while we're on a pause, if any House member has a question that you wanted to get in with Ms. Zimmerman before you have to jump off, we'd be willing to entertain that so that you can get it in before you go. Any questions burning for Ms. Zimmerman? All right, seeing none, you can continue.
Okay. So in general, they found that the government operated programs had in other states had a lower administrative costs and they served a higher percent of eligible households. Similarly, the categorical eligibility, the states that use categorical eligibility also had that. They also reviewed the state processes and they determined that there could potentially be savings of about $2.8 million by making these kinds of transitions. However, they identified some challenges, including establishing realistic timeframes and creating a cultural shift. In general, though, the report recommended aligning the eligibility with other benefit programs and fully integrating into the eligibility enrollment system. And they also recommended transferring the operations to the local departments of social services in those places where it is not already occurring. The department hasn't yet finalized the parameter work implementing categorical eligibility. And they indicate they have not finalized a decision on transitioning the administration of the program. We've asked them to comment on the timeline for determining that transition and the potential timing if it would occur. And we've also recommended committee narrative requesting an update on the implementation of these various changes. The other recommended action is annual narrative related to requesting information on application processing times, but this year it also includes a request for information about the denial rates. The second recommendation is the one that I just mentioned about the administrative and eligibility changes. And that concludes my presentation, and I'm happy to take any questions.
Thank you very much for that detailed analysis. Are there any questions for Ms. Zimmerman? Okay, seeing none, we will thank you again and turn to the Honorable Secretary for the Department of Human Services, Secretary Padilla. And your panel, I think you've got to unmute. There you go. Good afternoon.
Thank you, Chairman Griffith and Co-Chair Valentino Smith and members of the committee for the opportunity to discuss the fiscal year 2022 budget allowance for the Office of Home Energy Program. I have my team here with me today at the table: Stafford Chipongo, Chief Financial Officer; Bill Freeman, Director of Office of Home Energy Programs; and also in the room with us today is Lashira Ayala, Executive Director of the Family Investment Administration. I want to take time to thank you, Tanya, for her comprehensive and concise analysis. You have my testimony, which I'm not going to repeat. I know it's short time, and I would like, if you allow me, to just conclude my accomplishments by saying that now more than ever, we know the importance of the energy benefits that DHS provide, and we will continue to innovate and adapt to ensure we meet the needs of our customers. And now, with your permission, I would like to move to address the issues and recommended actions in the analysis.
Yes, please.
On the recommendations, the department concurs with the analyst's recommended actions. On the issues, issue number 1, regarding efforts to help ensure households receive benefits before utility terminations, I believe we have shared with you some of the efforts at a very high level. I can say that we are receiving a detailed list from the utilities on all customer-facing termination in the next 45 days. This list have been critical to have outreach activities in October 2020. And as January 31st, 2021, OHEP has received information for approximately 485 utility customers who have received termination notices. That's at a very high level. And then, if I may, move to issue number 2, DHS should comment on how it monitors spending. I can say that throughout the year, OHEP and the Department Budget Management Division work closely to review the benefit payment trends and the projections to ensure that funds will be available throughout the year. The OHEP reviews and updates its benefits on an annual basis using the benefit matrix, and the benefit matrix carefully considers projected eligibility numbers and energy costs, origin data, and other factors that drive demand for energy assistance. Moving on to the last issue regarding the integration of the OHEP program into the new eligibility and enrollment system on MD-Think. The department plans to fully integrate OHEP into the E&E system on MD-Think by July 2022. The other matters discussing the analysis are still being assessed, and we will provide details on any other administrative change to the committee in the recommended October report. This concludes my testimony and response, and I'll be happy to answer any questions that the committee may have.
Thank you very much. Are there questions from the members? Okay, I have a couple. And just to get started, and thank you for speaking to the issues and providing your responses. And I did receive your testimony, and so have an opportunity to look at that. I just wanted to get a sense from you in terms of the capacity. We have multiple energy programs, and just trying to get a sense of the capacity to get the resources out to people. And really, you brought up at the end MD-Think, and it seems to me if we had, maybe had those systems in place earlier on, as we came to this crisis, the eligibility issues and being able to have all of that information in one place might have helped kind of get the resources to the users more quickly. Can you talk to me a little bit about where we are both in, and I'm not sure, we may be having another budget hearing. I'm looking at Ms. Zimmerman that will deal specifically with MD-Think. but where you think that will help this process, and also how we're doing with staffing to manage sort of the capacity to get the energy resources out to the citizens. And I know some of them, I believe, are going out directly through the utility companies, if I'm not mistaken. But help me get my arms around this process-wise.
Thank you. Very good question. First, let me start saying that as far as internal resources, we believe we have the adequate resources to administer all our programs, and including the OHEP program. In terms of the MD Think program, we have moved very, very quickly. And I can say that so fast that compared to any other state that has attempted to roll out a similar program, they have taken 11, 15 years, and we have done so much in a very short time frame. Recognizing that when we submitted the plan to the federal government, we had a cascade. The first one was child care program, the child welfare. The second one was eligibility and enrollment. Eligibility and enrollment is the piece that touches the SNAP, the TCA, and that eventually would also touch the OHEP. And then the third one was the child support administration. So it's very aggressive. And to your comment that it would have been great if we would have the OHEP program in MD Think, I totally agree. But we have a very fast pace, and we're now aiming for 2022. And I believe that given everything that has been accomplished, we're very proud of the accomplishments and where we're at.
Okay, definitely keep us, and like I said, I know that we're going to be talking about that again in session. Also going to be talking about the family investment and making sure that we're maximizing the amount of federal funds that we use to meet our needs, so that we're not using more state funds than we have to if we can use federal funds. So we'll be following up with you on that as we move forward. Are there any questions from the members? Any additional questions or comments? Okay, seeing none, we will certainly look forward to seeing you and your team again in the future, in the coming weeks, and certainly we'll touch base with you offline should something arise before that time. But with that, we're going to say thank you to Ms. Zimmerman and to all of our staff and analysts today, and to you and your team. And that concludes the budget hearing for February 8th of the Subcommittee on Health and Human Services, and representing our colleagues in the House. So thank you and have a great week.
Thank you. Where is the end button? Oh.